I'll just share my screen. I hope my screen is visible.
Yes, Vivek, go ahead.
Uh, Thank you, sir. So I'll straight away move on to what is some of the evidence when it comes to risk factors for myopia. Specifically, when it pertains, I'll come to global as well as Indian evidence and some of the evidence about what works for prevention of myopia. So, classically, whenever we classify risk factors, we classify them as modifiable and non-modifiable. One of the key things that we look for in terms of not modifiable factors are: is there a gender issue at play? Is there a age issue at play? So clearly, there is evidence from Rudnicka et al. Which shows that gender, it's not really a risk factor. The black line in this graph is the odds ratio curve with age in South Asian population. And it is mostly trending around the odds ratio of one, basically meaning that, okay, gender is not playing a role in South Asian population in children when it comes to myopia. When it comes to age, definitely there is an age issue. This name slide is fairly, well known at this point of time. But some of the recent work that Professor Rohit and our team did in our NCR region was quite, interesting, in which we looked at children in rural, kind of semi-urban, peri-urban, you can say, areas in Gurgaon area near Delhi. And this was the NIM rural study. And one thing which we found very interesting was that, the type of school was extremely significant. The odds ratio was 0.016 when it comes to prevalence of myopia in government schools versus private schools. So that was quite important. The Then we also looked at risk factors in terms of outdoor activity. So what we realized was that uh, you know the children who were spending less time outdoors were having significantly higher myopia prevalence as compared to those who were not spending time outdoors. Now this is important because till now the evidence that we had was primarily from urban school children, and this was from rural population. And here we saw that there is a very clear cut demarcated huge difference between government and private school children, and something is happening here and we need to investigate what is happening. But it is consistent with our global evidence in terms of spending more time outdoors protects children from having myopia, prevalent myopia. This was a cross sectional study. Let's look at some of the what is the global evidence in terms of what are the other risk factors for myopia. So over a period of decade, there has been a significant increase in East Asian populations. In South Asian populations, there is a small increase per decade. Urban has 2.5 times the risk of rural, as if you look at global evidence. Uh, our recent evidence from NIM rural says that not all children are equal. There is some differences which are at play when it comes to government school versus private schools. Maybe it is pressures of study, maybe it is more time outdoors versus less time outdoors, more indoors versus less indoors. So when it comes to prevention of myopia, we can look at myopia in terms of primary prevention. We prevent development of myopia, or we look at secondary or tertiary preventions. So screening and provision of school, spectacle correction is a key, preventive measure when we talk public health. Conventionally, we would think of prevention as, okay, preventing development of disease, but preventing, the outcomes of the disease. 2/3 of the children are not using glasses. They are low vision. They are having low vision because they are not using glasses. So vision screening and school eye health is a key component, no doubt, when it comes to preventing the life impact, so to say, of myopia in school children. But when it comes to primary prevention, we have, if we look at the well-known evidence hierarchy, at the top we have the systematic reviews and meta-analysis of published trials, and then we have systematic reviews and meta-analysis of observational studies. In between, we have trials. So most of the data that we have, at least in India, comes from observational studies. We don't really have data from trials, but we do have some data from trials internationally about environmental factors for primary prevention of myopia. As I was saying initially, we have risk factors which are non-modifiable. So genetics, if East Asians have higher genetic predisposition, they have a higher genetic predisposition. We can't really do much about it. But we can definitely work on environmental factors which are, well known: increased near work, decreased outdoor activity, uh, maybe increasing screen time, which is being, is this really related to decreased outdoor? They have an inverse association: more screen time, less time outdoors; more near work, less time outdoors. So what works, we need to really see. But clearly, these are the three key strategies right now that we have for preventing onset of myopia. And these are also evident if you look at the Chinese National Program for Prevention of Childhood Myopia. They have a national level program right now. Some of the trials on this. So, the trial in Guangzhou, China, there was a 40-minute outdoor class at the end of school in children aged 6 to 7 years. There was a cumulative incidence rate of myopia of 30% in the intervention group compared to 40% in the control group. So a reduction, absolute reduction of 10%. In China, there was just 20 minutes, two additional 20-minute outdoor recess programs for 40 minutes per day. The annual incidence was more than 50% reduced. It was 3.7% in intervention group versus 8.5% in control group. Study in South Taiwan, children sent outside for all 80 minutes of their daily break. So there the incidence was even further reduced. 8% children in the intervention schools had developed myopia, newly developed myopia, compared to 18% in a nearby school where no intervention was happening. And the last one was about 30 minutes, 30 hours per week of outdoor activities. And the annual myopia progression was measured in diopters here. It was 0.38 diopters progression in intervention group compared to 0.52 diopters progression in the control group. So consistently, there is evidence from trials which shows that outdoor activity is preventing myopia. And the evidence is actually quite strong if we look at it. There was a meta-analysis of some of these studies which was done, in which, again, they said that there was no relationship between time outdoors and myopic progression among myopes, but there was a significant protective effect for incident myopia from trials and prevalent myopia from cross-sectional studies. So there is evidence which was there. And the more, as we see here, as we proceed along the x-axis, we increase the time spent outdoors, the risk of incident myopia goes down. So there is evidence of a dose-response relationship. In epidemiology, we talk about causality, and dose response is an important, indicator of causality. So it's a strong indication that if we spend more time outdoors, more reduction is happening. So there is a strong association. So if we reverse it, we can reduce the risk of myopia. There is some evidence from basic science research also as to how this works. There is a light dopamine theory, and the effects of light exposure versus physical activity, they were teased apart. And evidence from the Sydney myopia study told us that uh, when children are outside, they may be engaged in physical activity. So what is more important? Is being outside important, or is being engaged in physical activity important? So from the Sydney myopia study, the evidence is that it is the total time spent outdoors which is more important rather than physical activity. So then there is also a meta-analysis which was done, which also showed that there is no evidence of physical activity as an independent risk factor for myopia. So our direction basically is clear. We need to look at increasing outdoor activity, as an important environmental modification for preventing progression as well as incidence of myopia. There were no trials of near work prevention interventions, but the meta analysis which compared near work trials also said that there is no effect on incidence myopia if you reduce near work among children. So low dose atropine, enough has been said about it. So again, we come back to this hierarchy that we have global trials which have explored some of these environmental modifications. These work specifically in China, East Asian settings. Are they going to work in India? Very likely, yes. But we need more concrete trial-based evidence from our country. Meanwhile, the evidence, global evidence, is strong enough, and we should possibly be moving forward in implementing some of these interventions in our country as well. Thank you.
Thank you, Dr.